Are we ready?
Yeah, Oscar, you can start.
Okay, good afternoon to all our partners and sales directors, sales agent, etc. So first, thank you for those who came to participate to this special training. It is appreciated, first of all, and I've no doubt that you will get a lot of benefits from this training. Chris, do you want to introduce the subject of today?
It would be my pleasure, Oscar. So today we are looking at a sports-specific program. The module is referred to as the Performance Rehab Module. And so we have had it in the United States. We presented it at our first major conference for they're called athletic trainers, and they are a very specific sports physiotherapist. And so the module was received very, very well. And I think for a few reasons. One is it's something that is used by a lot of practitioners. So the tests that are in the Performance Rehab Module, they have a long history of being part of the return to play, as well as what we know today in terms of baseline testing. So there's a lot of great connection to what we have in the Performance Rehab app and what people are used to in terms of testing some of their patients and their athletes. But what we have to offer is also a lot more. So we've been able to accomplish this by adding more metrics that we see in the walk and the run analysis and making this a lot more detailed. And again, has gotten people very, very excited. So we are excited to present this to you today. So this is referred to as the PRM, or the Performance Rehab Module, and it also includes video. So we'll be talking about that here in a moment. I don't know if you want me to continue, Oscar, or do you want to talk about this, or you want me to continue?
Go ahead, Chris.
Okay.
Go ahead.
Yeah. So the rehab module and the video are part of a bigger picture, as we say. And this is the launch of DS Pro 2.0. So it's actually been a lot of work in developing the new firmware. And that allows us to do a lot more. So there's more flexibility in the system, and it allows us to create more detailed algorithms, having a better architecture at the helm, at the head of this firmware. So we're going to see this as a great opportunity to grow into some additional products. Now, it's a firmware upgrade, so we're still using the same sensors, the Digisol Pro sensors. So it was an upgrade. So those of us that already had the Digisol Pro, it was just an upgrade that we had to run through the apps. So this is going to allow us a little bit more capacity and flexibility. So we're able to capture more data, and we can get more technical in the computation. So these modules, they're using the Performance Rehab Module is using the exact same system. So I'm not adding anything. I'm using the exact same sensor. So I can actually take a person through a walk, a run, and then the Performance Rehab Module without changing anything. It's all based on the exact same platform. So we've got some additional to the walk and the run. So we'll see that this is the jump module that allows us to perform 4 different tests, and we'll talk a little bit more in detail. We've also added the video component, and the video component, it's simple, but it's a visual aspect that has been a great tool in presenting this to the patients. So now they really get to see themselves. They can visualize themselves in all of that data that we've been presenting in in the analysis. We're also able to update some of the patient records and provide a better output and dashboard to this information, making it a little bit more presentable to the patient, but also making it easier for the clinician to look at, evaluate, and export some of this data. We also have additional workspace opportunities, so it gives you a little bit more flexibility in the licensing and the availability of presenting the product to the customers. So this is just an extension, so it's using all the same information, and it will just be an upgrade to the existing system. So if someone already has the walk and the run system, DS Pro, they'll be able to just simply add this as a module. And because of the firmware upgrade, as we continue to develop new products, it will continue to allow us to add more modules to the system. So we're following this segmentation or pathology and patient approach in how we're able to use the same system, making it a little bit more detailed for each level. So as you enter into an opportunity to sell the product, then you can identify where their focus is going to be, and you can channel your message more appropriately. So you're not selling them something that they may or may not need. So this is just an extension. Like I said, it's the same system, but it really adds another dimension, especially those that are working with an athletic or a physically active population. We keep saying athletics and sport, but that also includes people in recreational activities. And we'll talk more about that when we get into some of the details and the specifics of an ACL injury, for example. So ACL is an acronym. It's an abbreviation for anterior cruciate ligament, and that's where a lot of this started. So as we move forward, we'll see where this is potentially going to fit and allow you another opportunity, another sales position, especially those that are working with a physically active population. So it's for both the healthy as well as the unhealthy. What we've been able to establish in these, like I said, these tests that we've put into the system, originally they were designed as a what we call return to play, or reathleticism is allowing us to determine after the rehabilitation process, is the individual prepared to go back to their level of physical activity before they were injured. Because these tests are now a little bit more specific and detailed, they've been around long enough where the research has also allowed us to prove that these tests can be used in the healthy population as a performance analysis, as well as using it as a baseline tool. So that way, if someone does get injured, we know where to bring them back to after the rehabilitation process. So we're adding another dimension to the tools that we already have, as both baseline testing, as well as during the intervention to follow the evolution, as well as to look at the return to play or the return to physical activity after an injury rehabilitation process. So why did this get built? So it really was built around the concept of the ACL injury. So ACL again stands for anterior cruciate ligament. And so that's the ligament inside of the knee, and it's one of the two cruciate ligaments. So there's an anterior and a posterior, and they're named for the location at which they're in the knee. Now, that particular ligament is very important at establishing the extension moment of the knee as well as the rotation. Okay. And that's why it falls under a great deal of stress. So the orientation of that ligament can be an important factor as a potential prediction, as well as the performance aspects that we find in individuals. The majority of surgeries that occur at the knee for ligament repair are going to be the anterior cruciate ligament. Because of the structural differences between males and females, we do have a much higher ratio in females, especially at that younger age. What we do find as they get older it evens out a little bit. And part of that is also going to be due to the fact that someone got into a very high level of sport, or they're not involved in physical activity at all. 65% of these are actually related to sport. So, in other words, they're playing a sport, they're involved in a sport. And also, a very high percentage of those are considered to be non contact, meaning that it wasn't because of an impact injury due to another player or another structure on the court or on the field. It was typically involved in a landing, a deceleration, or a change in direction. So no one else was around that athlete. Unfortunately, it just happened because of the structure being overstressed and then giving way. We also see this in the non-sport orientation. So people that aren't necessarily involved in sport, but it could be due to other types of physical activity. It could be work related. And again, we do see that orientation, that structural influence, especially early on. But we also know that it's related to some of the things that we can actually change, which is a good thing, because when we do rehab on these folks, or if we can test them and we can predict them, that's an even better thing, because we can reduce the chances of that happening. This statistic, 40,000 ACL injuries, I believe that's in France. In the United States, we see it varies from year to year, but we tend to see about over 200,000 ACL surgical procedures that happen per year. So the 25% reoccurrence rate, in other words, it happens again, and usually it's in a fairly short period of time. Often 1 to 2 years is when it's going to happen again on that same leg. We also have statistics that show that it can happen on the opposite leg, because they're predisposed. It happened on that first leg because of could be structural differences. So they're going to be predisposed to happening on the other leg. So you can see here that a lot of these cases occur in the younger population, especially between the 15 and 19. So that's typically as they're in that high school level into the early college level. And because of the reoccurrence rate is also higher at that level too, this is a really important range that we want to really focus on. And that's why the general population physiotherapist or sports conditioner sees a lot of those patients. And there are statistics that say that we need to do a better job at testing these people to make sure that we know exactly what's going on. I don't know if you'll be able to hear the volume on this, but this is just what to look at.
And that one, it's in French also, so you can forget it.
That's okay. It's a beautiful picture, though.
Yeah. So
Okay.
Again, everyone can
So-
find a video on internet, on YouTube.
So this is just looking at the anatomy of the structures. So this is your anterior cruciate ligament, and that's the one that gets injured during a particular process. We have some basic evaluations. I used to be a sport physiotherapist that we specialize in being at the sport activities. And so when we can evaluate a knee injury very soon after being on the field, before the hamstring muscles, the muscles in the back of the leg, start to protect it, we can do what's called an anterior draw test. And that's a very good test that we can use to define whether or not that particular ligament has been damaged. It's a little bit more challenging to perform later on, after they've gone to the hospital, and maybe a week, 2 weeks, 3 weeks later, they end up in the physiotherapist department. So what happens is there's a lot of restriction because that knee joint is being held by the hamstrings. So the hamstring muscle group becomes much more active following this particular injury. So it's a little bit more challenging to determine whether or not that ligament has lost its overall integrity. But there are ways to look at that. So we could do an MRI, which we know is very, very expensive, or we can do this test right here. So this is a specific test. It's a dynamometer that we can use to evaluate that translation of the knee much better than we can do with our hands. So this is one of the ways that we will determine whether or not someone is going to go through conservative treatment or through surgical treatment. So if we've identified that we don't think that there's a complete rupture or enough of a rupture to go in and do a surgical intervention, we may initially attempt a conservative treatment first. Now, even if we're wrong, that's actually okay because we can perform and use that as a pre-operative opportunity, making the structure stronger. And it means it's also going to recover much better and a little bit more easily. Other characteristics that we'll use to determine is what is their level of physical activity? And it could be related to the age of the patient, but not always. If they're younger age, this is very common done, even if they're not going to be a high level athlete. And the reason is that there'll be too much structural integrity loss. And the studies are very clear that it means that they will result in osteoarthritis by middle age, and they're going to need a joint replacement. Now, studies are also pretty clear that a high percentage following surgery, those people are also going to require a further intervention due to osteoarthritis, but the percentages are actually going to be lower. And then it's sometimes up to the patient. So I've rehabbed some very active patients that decided not to have the surgery. They do require bracing because there is a laxity issue. There is a change because remember that ligamentous structures do contain some neurological components that also assist people in their movement capabilities. So this is also in French. So let me just scroll through that real quick. So that's an actual tear of the ACL.
Chris, we don't see your PowerPoint anymore.
Uh-oh. So that must be the video. Let me try that again. Actually, it just kicked me out total. You can hear me? Can you hear me?
Yes, we can hear you. We can see you, but not the presentation.
Yep, it stopped presenting. It could be because of the video. So the video that's being shown is just a video of looking at that tear of the ACL.
Yes, now we can see your PowerPoint.
Okay. And it's also in French, but so the ligamentous structure gets torn, and again, it's just outlining the opportunities for the different types of treatments, conservative versus the surgical treatment. And so the surgical treatment there's typically three options or three different donors. One is going to be they take the middle third of that patella ligament. So they take out a portion of the bone from the patella. They take out a middle portion of the ligament to where it attaches to the tibia, the lower leg, and they take out a bone portion there. And they make a hole inside the top of the tibia, and they make a hole at the bottom of the femur, and they attach each side of that bone into that area. And that's what's referred to as a patella tendon graft. They also have an opportunity to use cadaver grafts. And then usually the last option, especially if they've had multiple injuries to that particular ligament, is they actually take part of the hamstring muscle and they use that as an attachment directly to the anterior surface of the tibia through the posterior of the femur. So really three options. The patella tendon graft is one of the most popular because it's using the patient's own tissue, and it's not going to change the integrity of the neuromuscular component as if you were to take a muscle tendon and sneak that through. So we have multiple phases during the rehabilitation process. if we have an opportunity, and this can be a little bit different from one country to the next, depending on the healthcare system, but we do have a preoperative phase. That gives us an opportunity to actually try and take the patient and build them up as strong as we can, minimize the inflammatory cycle before they go into surgery. It's not an emergency procedure, so we do have time before that. Typically, the only limitation is going to be if they are a very high level athlete. We may want to make sure that we get this done so we can prepare them for the next season. The typical rehabilitation process is going to take oftentimes between 9 and 12 months. So that's where this pre-op phase can be really important in improving their mobility, decreasing their inflammation, increasing the strength, and preparing them for the surgical process, and hopefully making their recovery is going to be easier, it's going to be faster, and it's going to have a much more successful outcome. Unfortunately, with all of these younger people that don't have access to high-level sports medicine care, a lot of times they don't get to perform a lot of that pre-operative rehabilitation process, and so that can be a challenge for some of us. So I've already described the operation procedure. It's very similar in that we use a bone graft in the femur, we use a bone graft in the tibia, and it's a procedure that just takes a few hours typically. And studies are very similar in terms of the level of recovery. Initially, we thought if we used a cadaver, it would improve or accelerate the recovery process, but it doesn't seem to necessarily be that. And in fact, it's the plug that takes longer. It can create a little bit of challenge because we've created some destruction in some of the parts, such as the patellar ligament, but overall, it tends to be a very successful surgery. There are also some additional complications, which we have one reference called the unhappy triad. And the unhappy triad is when the athlete tore their ACL during non-contact, especially during rotation. And we also see a tear of the medial collateral ligament and structural damage to the medial meniscus. And so that could elongate the surgical procedure and potentially make it a little bit longer. So during the process of prehab, we do have an opportunity to have them do some exercises again to increase the strength. One of the side effects of having knee joint surgery is this phenomenon where we see a decrease in quadriceps function, right? And that's going to be a very important aspect during the rehabilitation process. And so it's kind of amazing to see the change in pre versus post-operative just within those few hours. Is we see a dramatic decrease in the size of that quadricep muscle. It becomes inhibited. It doesn't function very well. And so that's why if we can perform the physiotherapy preoperative process, and that can include very similar activities that they're going to do post-op, but very similar to what we would do in the normal exercise rehabilitation process. So single leg, double leg squats, lunges, we can add some plyometric activities and allow them to really build themselves up as much as we can. Now, we won't let them really play sport because that's going to be the uncontrolled mechanism that caused their problem. But with a knee brace, they can actually perform a lot of activity and spend a lot of time in that pre-op phase. And then phase one, so after they've come out of surgery, initially our focus is to reduce inflammation. Inflammation is a limiting factor in moving to the next phase, right? Because the presence of inflammation, the inflammatory cells, inhibits the body's ability to then start repairing and laying down new tissue. So initially for those first few weeks, it's really focused on making sure that we reduce inflammation, as well as any side effects associated with a surgical procedure, which include infection and deep vein thrombosis. So a lot of times, some surgeons will still use a CPM, which stands for continuous passive motion, but we try to get them as mobile as possible, as quickly as possible, especially in a non-load bearing activities. So we do actually want to start moving them as quickly as possible. The other thing that we're going to do is we're going to focus a lot on pain management. And that's important because that's going to move us to the next stage, and that's going to allow us to begin the reinforcement and now start to build up that tissue, reestablish muscle activity, instigate the healing of the structures that were damaged in the injury, but also damaged in that surgical procedure process. So that's where we're going to begin some physical activity that is going to start loading that tissue. When we start to load that tissue, that actually causes the body to start laying down more and new tissue. It increases the activation of the musculature. And some of this, again, is still going to be in a non-weight bearing activity. Now, we started with a full leg knee brace to make sure that we limited and we didn't have too much extension, right? Because that puts too much stress on that anterior cruciate ligament. So we're using typically a full leg brace at that moment in time. They can start to begin mobile, and we often have them do walking activities, and cycling is very, very popular, where we do what are called half moons or half cycle activities, and we can start to begin that strength training process. We will also use typically some neuromuscular electrical stimulation. We'll continue to manage the inflammatory cycle. We're also going to start giving them some more physical activity, functional activities that are going to mimic typical human movement, similar to what we were doing during that prehabilitation process, and really focusing especially on activating that quadricep muscle that's on the inside of that knee joint, referred to as the vastus medialis or vastus medialis obliquus. And then as we continue to move forward, we're going to get much more active, and we're going to stop using really basic targeted types of activities and get more into the functional activities. And this is where the reathleticism comes into play. So we're going to have them start doing more types of activities where they're much more weight bearing. They're going to begin to start changing direction. We're going to begin to start overloading with various types of sport activities in a very controlled manner in the rehabilitation facility, to make sure that we're not overstressing or causing some of those problems. We're really going to start focusing on building back that other strength. Now, we may also be testing, and we're looking at a comparison between the injured limb and the non-injured limb. And that's where our focus at the end of the rehabilitation process is. We want those to be as close as possible. So we have various ways that we can measure that. And that's where the performance rehab module actually came into play, is we're going to be able to use that throughout the cycle. If you were to look at a very detailed view of the rehabilitation process in the ACL, you will see where we start, and we may do walking. And then to go to the next level, we evaluate walking. We want to make sure that they're not in pain, but also that they're symmetrical between the right and the left side, because that's a lower level of stress. And that's our indication to move forward. So you can see where we might want to start with and use a walking analysis. And then as we get to the reathleticism, we're going to start increasing the loading and the level of physical activity. And that's where the running analysis may come into play, as well as some of these jumping activities, only if they're cleared at that level. But because running is very, very linear, it's a great opportunity to capture some of that data that looks at the comparison between the right and the left. And then as we get into that later phase, that's where this performance rehab module, or the ability to do some high level comparison very easily with our system to make sure that they are at an appropriate level to return them back to play. So the focus is really looking at the symmetry between the right and the left in terms of these characteristics. And usually it's going to be related to strength and power. And that's why a lot of these tests are referred to as jumping or hopping tests, because we're able to capture that very simply. But with our system, we're going to be able to do a little bit better job at that, because we're not only going to be able to look at that basic quantity, but we're going to be able to look at the quality of their overall movement pattern to make sure that the re-injury process is not going to be as high. And the other problem with just looking at comparison between the two legs is you better know that the other leg doesn't have a problem either. So if it's not working appropriately, using that as your metric or your only marker in terms of just jump height or distance may predispose this person to have a re-injury in the surgical leg, because it's not up to where it should be, as well as a potential injury in the other side. Now, ankle sprains, other lower extremity conditions from the ankle, the knee, as well as the hip. So we've been able to determine that a lot of these tests can be used very similarly, and they work as a lower extremity index and allows us to evaluate the lower extremity in general. So just for example, looking at the ankle sprain, we see that we have many, many ankle sprains, and actually we see more ankle sprains than we do with ACLs. So these tests have also been validated as a method to determine the level of prediction of instability in the ankle as well. So we don't want to just say that this is only for ACL, because even as we found here in the United States, it is very important, because it has a factor associated with their life cycle. If it happens when they're younger, it could influence their life later on, and we don't want to have to do any more joint replacements than we have to. But know that we use this as an overall lower extremity screening process to look at the functionality, and we can look at, and there's data that shows us that ankle instabilities can be evaluated with very simple tests. And so during the re-education process, following an injury, or even in the prediction of an injury, we actually use a pretty similar process. So if they are going to be injured, like I said, the first thing is we typically decrease the inflammatory process, manage the pain. That's going to allow us to move forward, because with inflammation still in the compartment, it inhibits the body's ability to generate new tissue and to repair that process. And that's why it's real important that we minimize that. Then we get into just increasing the strength and the viability of the tissues that have been injured. Then we get into the functionality. And then we go to the highest level, which is restoring the ability to perform at a better level than just simply activities of daily living, right? So again, that could be reathleticism, or it could be just getting people back into physical activity. And that's why it's important that, we push that as practitioners, that just being able to walk isn't enough to keep people from, potentially having future health problems, and that we want them to be as physically active as possible. I always say to my patients, I would much rather treat you for an activity related problem than a sedentary problem, right? Because that means that they're active, they're going to have less risk factors associated with some of their other conditions. So as an extension to the walk and the run, we now have this jumping activity. Why jumping? Jumping is a great way to add a lot of extra stress onto the body and mimic activities that we see in sport, or even some of the things that people do in recreational situations. So we've got a counter movement jump, we have a triple hop, we have a side hop, and we have a single hop. Why were these chosen? Well, because they're validated in the literature and they're very commonly used. And so having those two components means that when we approach a potential customer, it's not going to take a long process to convince them that this is going to be a valuable tool in their clinic setting, right? Because they're already using a lot of these tests, they're familiar with these tests, and it's going to give us an opportunity to show them that we take it a step higher. So measuring the counter movement vertical jump. So the counter movement vertical jump is used as a performance test. Typically, it's a test of strength and especially power. And so we're looking at the displacement, right? How high they can actually jump. As you can see here in the picture, it's really simple. It's very well validated, and it has two really high correlations. One is to sprint performance, how fast someone can run that 100 meters. And it's also validated against the 1 repetition maximum in the squat exercise, which is also related to sprint performance, which again, if we're thinking about that athletic population, those are other maximal tests that we use to predict performance. But yet the vertical jump is a lot simpler. It's easier to administer. I don't need a track that's 100 meters long. I don't need to do a 1 repetition maximum, really intense activity. So it's a great activity that we use a lot. Even in grad school, we used vertical jump measurements every single day to look at the evolution and changes in the training schedule related to volume load. And this was back even before we had all of this technology. So it's a counter movement vertical jump, which means they start in an upright position, they go down and they go up. We typically have people have their hands on their hips. So that way, when we retest them, we make sure that we test and retest the exact same way. So that adds to the level of specific and sensitivity when using this particular test. So we do get the basic parameters, which is going to be jump height. So jump height is their displacement, and it can either be measured through center of mass, which is our typical calculation that we use when we have technology. So we use it as a marker. So we have data that shows that different athletes at different age levels and in different sports do have some variabilities in where I can actually show a patient that, oh, so you want to be a baseball player, here's the typical jump height that a baseball player is at that particular level of sport that they want to play, or basketball, or whatever sport that it is. So it gives us their displacement, and that's the most basic characteristic that people have been measuring for a long period of time. But as we'll see in a moment here, we get a lot more detail regarding that. The next one is going to be the triple hop. So the triple hop gives us a maximal evolution, right? So we're using displacement horizontally, which is a little bit different than just the vertical jump height. So this one incorporates some motor skill, right? Because they need to be able to be in control. And on that last hop, they need to land and what we call stick that landing, which is be able to stick that landing and remain stationary for 2 seconds without falling from side to side, without falling forward or backward, or doing an extra hop. Okay, so this is one of the tests that we use as a predictive test in return to sport, or as a baseline assessment to look at the level of asymmetry. So the asymmetry that we're typically evaluating is going to be the distance, the accumulated distance of all 3 hops. Now, this is a test that so many people are already doing and are very familiar with, right? And so that's why it's a real easy discussion to have with clinicians. This test is also validated as a test of strength and power in performance. So not just for injury, not just for prediction of future injury, but also as a performance indicator that, again, I can use if I am training an athlete to perform at a better level. We'll look at the characteristics here in a moment, but one of the things that I really like is the fact that we get ground reaction time. So whenever I see a deviation or a problem when I do a running analysis on someone, I have them do a triple hop and a counter movement hop, because I get to look at the assessment and the evaluation in ground contact time, which is an indicator of their ability to what we call load and explode, right? Which is a land and then a transition, right? And the nice thing about the triple hop is it's supposed to be a maximal effort. So they're supposed to try as hard as they possibly can. So different ways that when we see the asymmetry, either as a result of the ACL, or hopefully we can maybe get them tested to a baseline and prevent an ACL. So we have various types of activities that we can use if we find that it is a balance issue, right? If we look at their trajectory and their balance, it could be a stability issue. So we do wobble board activities. We do strength activities from single leg squats and lunges do double leg squats, and various types of balancing activities. The single hop, this is very common also in a lot of clinics, because if they don't have a lot of space, it's very simple. It's also been highly correlated to the triple hop as that asymmetry assessment in return to play, right? So it's a little bit easy to administer. It doesn't give us as much data as the triple hop does. It's typically not used as much as a performance indicator, but it is your very typical asymmetry assessment as a return to play characteristic. And of course, what we know now is also as a performance indicator predicting of injury. Same thing, the target is going to be a 10% difference between the two legs, means that that's a bad score. If they're within that 10%, it means that it's a good score. And that's one of the criteria that we use in lower extremity indices to determine whether or not they're going to be eligible for return to play. Similarly, when we look at the difference between the distances that they jump and some of the characteristics that we capture from our system can lead us down the pathway of a good intervention program, which again, if we determine if it's strength, if it's power, it could be adding some plyometric activities into their training regimen, strength activities such as the double leg squat or the single leg squat or lunge activities. If they have difficulties jumping and landing, right, because same criteria as the triple jump, last jump, they need to stick that landing and maintain that for 2 seconds without falling side to side, front or back, or doing an extra hop. If they can't accomplish that and try and do a maximal jump, then it usually means some motor control or ankle stability problems. And we figure some of that out with some of our manual assessments as well, looking at range of motion and things like that. So that gives us more information to determine what it is that we need to do with these particular individuals. The side hop. Now, the side hop is it's an excellent test. It is, as we call it, it's very strenuous. So the distance between the two borders is 40 centimeters. It does not seem like a lot, but when you're jumping on one leg and you're doing this for 30 seconds on each leg, so it tests the endurance, it tests the motor control, it also tests the stability of the ankle, the knee, and the hip joint. And we'll look at, again, some of these more specific characteristics. And as you can see, jumping on that one side, you're going to look at medial to lateral and lateral to medial forces on each foot. We will look at the comparison and we count the number of jumps between the two, and that is another 10% characteristic that we use as a return to play criteria. But with our system, we also get something that I really like, which is ground contact time, flight time, and again, some of the things that we'll look at, but we get a little bit more detail that we can use to determine what some of the issues might be, right? So not just looking at the number of jumps, which classically is what are used in most of these tests because people don't have the technology, but as I said earlier, now I actually get to look at the quality of their jumping capabilities, which there are studies that show if you do have the technology to do that, they're better indicators of potential problems that are causing these asymmetries or potential future problems. So we look at the number of jumps, but it also gives us our ability to look at some of those other characteristics that we see in these other jumps, which is again going to be performance, stability, and range of motion in the ankle joint, but also giving us some indication as to what's going on in the knee and the hip joint. Okay, so 4 different jumps. Sometimes we may use all of them. Sometimes we may choose 1 or 2 or 3. It just depends on what exactly it is that we're trying to accomplish within the test. It's real simple and easy to move through. Again, it's the same sensor, so I can run all of these tests on one person. It takes about 8 to 10 minutes. And the reason for that is not because the tests take long. The tests don't take very long, but it's because of the recovery in between. Now, typically we'll save the side hop for the last, because that one is the most amount of stress. And so if you save that for last, you can actually get through this testing procedure in about 5 minutes. So it doesn't take very long, but you're going to get a lot of information. We're going to get very similar characteristics, metrics, and parameters from all of the tests, which is going to make it easier for clinicians to be able to read through this very quickly, because seeing the same repeated parameters is going to make it easier for them to learn and understand. So we get flexion takeoff, and we're also going to get position at landing, which is nice because maybe there's a change, or part of that the symmetry difference is because of ankle range of motion. So with that sort of information, we may know that there could be a problem in ankle range of motion, and that's going to lead me to part of my my intervention process. We also get how quickly, right, is going to be the angular velocity. So we're going to get ankle position at takeoff. We're also going to get angular velocity, how quickly they're moving from a static position into that takeoff position of all of these jumps, right? And so we're going to be able to also do that comparison for all of these metrics between the right and the left. So that can be an indication as to whether or not there's a weakness, and it's related to strength or power, as well as stability. The contact stability, this is a very interesting one. So those clinicians that are familiar with Romberg's quotient or Romberg's assessment, which is the rapid deviation from a center position. So the contact stability, what we're able to capture is on strike, we're looking at within the first 200 milliseconds, the amount of deviation into that pronosupination position, as well as how rapid that takes place. I just gave a presentation on running ability, and one of our predictors in running injury, for example, is they slap that foot down and they move way too quickly from heel strike, which typically is going to be in a supinated or heel inverted position, into that pronated position. If they move too rapidly, that's actually considered a predictor for potential running injury, especially if there's a degree of asymmetry. It tells us they have a motor control or a weakness problem. So we're actually able to capture that here with our system. Maximal acceleration at landing. So if you're familiar with the running analysis, we see that we do have contact force, very similar here. So we can look at the comparison between the right and the left. Now, we don't have any standardization or normative data, so we at least use this to compare the right and the left, as well as look at the evolution as a result of the training process. Rotation around the z-axis. So some people are familiar with the Fick angle. So this is the degree of external or internal rotation, which takes place between the ankle, the knee, and the hip, which part of that is due to anatomical features, but also due to motor control strategies. This is really great because it tells us the amount of deviation. One of the things that happens as a result of deviation in the external rotation position means that they're putting more stress on that knee. So when we combine this with pronosupination as well as contact stability, that's a lot of great information that says that this person is applying too much stress that could have an integrity problem on the knee. And if I take a video, you might actually see that dynamic knee position, and I'm able to show the person that that's a problem. So there's a great study that shows that once we approach 30 degrees, we're really overstressing that position and could be a link to a potential future problem, even if they have normal jump heights, right? Because that's a strategy in landing. And that's why I like to see that, especially in the triple hop, because I can see that evolution. So I have a case where they landed and they were at 11 degrees, and then at 21, and then at 30 degrees. And I think to myself, man, I wonder if they took one more jump, what would that look like, right? And so we get to see that evolution even within that particular jump. The flexion plantar flexion on landing, or dorsiflexion if they're doing a hop test. So we get to see that foot position and whether or not that angulation has anything to do with range of motion at the ankle, and indicating either because of weakness or we need to do some stretching and improve that range of motion about that particular joint structure. So the pronosupination, so very similar to what we have in our other analyses, but again, that particular characteristic, when someone goes into a very pronated position upon landing, that is a potential weakness problem, as well as resulting in overstress to the medial aspect of the ankle joint. But more importantly, what we really typically look at with regards to that is going to be the resultant stress that is put on the knee joint, which could be a predictor of the knee joint injury, including an ACL. So hop tests, actually, we do have some standardization. Typically, we see a comparison between the right and the left. We can compare a normal person to an athletic person. So we do have some standardization in what those numbers look like, even though initially these tests were specifically designed to look at the symmetry characteristics. But as I said, the evolution over several years has, well, if we're already collecting data on these tests, could they be used as performance measures? Could they be used as predictive measures? And the answer is yes. And that's where we've been able to see a buildup of some of these normative values. Oops, I moved pretty quick. Whew. I know it's a lot of information, but we got a lot of videos on this too. So this is the video aspect, and it's in conjunction with the DigitSoul Pro. So when you prepare to do an analysis, if you have this feature that it asks you a question, would you like to perform video analysis? You don't have to do anything extra. You record the video from the mobile device that you are using to collect the analysis of the walk, run, or the performance rehab. So yes, you can use video analysis on all of these. It embeds it right into the mobile app, and it also embeds it into the online web app, and it saves that. So the nice thing about having that, the nice thing about having that opportunity is I can actually download that, right? In the app itself, I can show the patient or the athlete, and I can slow it down or I can stop it, and we can at least look at positions. But it also allows you to download this file, and I can put it into one of my other apps if I want to get a much more detailed orientation. So this is me putting it into my Markerless motion capture system. And it's the same video that we took, but it saves it right in the patient file and allows me to view it from the mobile, from the online app, show people their position during the orientation. It's not really fancy right now, but it's been a great addition to a visual for showing people. So that really has added, to the advantages of using this system, to where, again, it's very portable. That's my son right there, by the way. It's very portable. So I can take this on the field. I can take it to the court. I can use it in the clinic. It's so easy to set up. All of these tests are from that one sensor, that one pair of sensors that we put in the shoe. And we get a lot of data that is very, very informative, easy to share with the patients, other clinicians, caregivers, and have this information at our possession. So we do have a flyer specifically for the performance rehab module with some basic statistics on it, which are pretty powerful to show that this is very informative. There was a study, an article published in a peer-reviewed journal of orthopedic and sports physical therapy, and there's a moratorium, which is it's a call to action to say that we need to do a better job at preparing people for return back to physical activity, because that recurrence rate is unacceptable, especially given the cost of those of those surgical procedures and what's going to happen in the future. Another flyer looking at and highlighting the information that we've discussed, as well as the parameters, easy to use, the information that we've seen before. Another trifold, again, providing a lot of information. Also an opportunity for you to brand it and put your own information, contact information on the pamphlet themselves that you can leave back with the patients. So again, this is a continuation and segmenting process, and I think Oscar might want to say something.
Yeah, I just want to mention regarding the flyers and the leaflets that we already discussed about in the monthly partner meeting, but just a reminder that it's actually exists in the distribution portal, okay? So the distributors, they just have to go to the distribution portal, and you have it also in a version that you can change the text and to do it in your own language, okay?
Yep. Excellent. So again, this is a continuation, and our hope is that this helps you to identify where the product can better match your target market, especially when you've identified that and you can approach them with the appropriate solutions to their situation.
Okay.
Whew.
Chris, thank you very much. I think it was very efficient training. I just want to mention, to add a few things. So regarding the leaflet, I already mentioned it. One require for the distributors, I saw that there are some distributors that came not with all the sales agents, the sales reps. So please, I really requiring it to share this training with the sales team, with the sales agent, with the sales reps. It's so important that each of them will go through this. And as well, those who came to and participated here in live, it's important to come back and watching this again and again, because I'm sure that you can have like questions, comments that we will be more than happy to answer. Chris is always complaining that after this training, there is no questions coming up. I told him it's because
we do such a nice job, Oscar.
That's what I'm saying, but seriously, please go through this. Put your comment, share it with us. If you have some questions, send it to us. It's really important. We will answer to all the questions. I'm sure that as more as you and your sales reps will have will watch it and will learn it, you will be more comfortable in front of the practitioners. Your speech will be improved. There is no doubt about it. We can see it from training to training. So please take it to your attention. There is another thing that I wanted to mention regarding the prices of the modules. So this is something each of the sales directors doing in front of his distributors. I already started to do it with some distributors, I guess the Roma as well. So if you have some lack of information, things to be clarified, questions regarding the price, the business model, again, we are here 24/7 for giving you the answers, to give you the service, and to make sure that when you are in front of your customers, your practitioners, you have all the information needed. So I think I covered most of the points. Rana, you have something to add?
Nothing from my side, except that we're always here to get your questions, your concerns, and information that you require. And I can channel that to Chris if there's something that we cannot answer. He's the expert, so he will come back to you. We can share with you also this PowerPoint. Perhaps you might take a few slides that you would like yourself to present to your practitioners, so you will get that by email probably by tomorrow.
Okay, great. So in this case, you can share with those who didn't participated. Just before we finish, I just want to say again, congratulations to our South African distributors. I noticed that we had like 7 people from South Africa. So like always, great job, guys. And I hope to see more and more people participating in live in the next training. Okay, that's it from our side.
So thank you everybody for being here. Do not hesitate to contact us if you have any questions, and probably we will have another training next month. So we will open door number 5 next month, and we will announce this to you in our next monthly partners meeting. So thank you, and see you soon. Bye.
Bye. Take care.
Thank you.
Bye. Thank you again, Chris.
My pleasure, always.